Hi, my name is Ben Ockery. I'd like to tell you about an upcoming article that will appear in the Mayo Clinic Proceedings. I was the principal author on this article entitled Postoperative Acute Respiratory Distress Syndrome in Patients with Previous Exposure to Bleomycin. Other contributing authors will include Daryl Kaur, Greg Wilson, and Richard Etham, and the principal investigator on this research was John H. Eisnock. We evaluated patients that had received bleomycin and underwent a procedure between the years 2000 and 2012. These years were chosen based on the advent of the intraoperative electronic medical record at the Mayo Clinic. We found 1,120 patients who had received bleomycin and underwent a subsequent procedure. Of these, 316 patients met our inclusion criteria. Inclusion criteria included patients who had a general anesthetic requiring endotracheal intubation and greater than 1 hour of general anesthesia. Heart, lung, and liver transplants were excluded, as were those procedures that were greater than 1 hour but were minor, such as a biopsy. Historical risk factors for post-operative pulmonary dysfunction after bleomycin include patients over the age of 70, patients with renal insufficiency, patients receiving high FiO2 intraoperatively, patients who smoke, and patients who received a cumulative bleomycin dose of greater than 450 units. The rationale for us doing this study was that historically patients treated with bleomycin are at high risk for postoperative pulmonary complications. Over the years, however, our ventilation strategies have changed, as has our intraoperative management of these patients, such that our clinicians at the Mayo Clinic have noted a very low risk of postoperative ARDS in these patients. Therefore, we sought to identify the true incidence of postoperative ARDS in these patients, as well as identify those risk factors that can be modified intraoperatively. Bleomycin is an anti-tumor antibiotic first identified in the early 1960s. It's used to treat germ cell tumors, lymphomas, and Kaposi sarcoma. It's highly effective, but the limiting reagent in regards to its use is pulmonary toxicity, which may occur early during acute treatment, but often manifests also as postoperative pulmonary toxicity in patients who receive general anesthesia. Of our 316 patients, we found 7 cases of postoperative ARDS. If we looked at patients who had received bleomycin and this was their first procedure, there were 6 cases of ARDS for an incidence of 6 out of 315. Because our incidence of the postoperative ARDS was so low, we included a 7th patient for statistical analysis. Our definition of acute respiratory distress syndrome was the Berlin criteria to match contemporary nomenclature. Major findings from the study are that the incidence of postoperative ARDS in bleomycin-treated patients is exceedingly low, much lower than would have been predicted. The research supporting this theory comes from the late 70s as well as some work in the 80s and early 90s. No research has been done on this topic for quite some time. Historically, patients treated with bleomycin undergoing subsequent anesthesia benefit from reduced intraoperative FiO2 as well as judicious use of colloid and crystalloid fluid replacement. Our hypothesis was that intraoperative FiO2 as well as fluid replacement would not correlate with postoperative ARDS. The goals of our research were twofold. First of all, we wanted to identify the true incidence of postoperative ARDS in these patients. The second goal of our study was to identify the true intraoperative, preoperative, and perhaps postoperative variables that would correlate with postoperative ARDS in these patients. Our results were as follows. We found a total of 7 cases of postoperative ARDS out of 316 patients and 541 procedures. All of our postoperative ARDS patients were white males. 6 out of the 7 were current or former smokers, and 5 out of the 7 were on a proton pump inhibitor within 90 days prior to their procedure. Other significant risk factors were intraoperative colloid and intraoperative crystalloid administration, with patients receiving more volume being at higher risk for postoperative ARDS. Of note, intraoperative FiO2 did not correlate with postoperative ARDS. On average, patients with postoperative ARDS received 54% FiO2 versus 51% for those patients that did not have postoperative ARDS. The trend was toward higher FiO2, but the results were not significant. Now, future directions regarding this area of study would need to include more patients with postoperative ARDS, perhaps a multi-center trial, in order to be able to identify true modifiable risk factors. For practitioners, the take-home message of this research is that patients treated with bleomycin are probably at a higher risk for postoperative ARDS, but the risk is probably overstated. Of note, our incidence of postoperative ARDS is very similar to the average rate of postoperative ARDS for a patient undergoing an intra-abdominal procedure. Therefore, my recommendation would be to not restrict FiO2 at the expense of hypoxia. Furthermore, judicious use of colloids and crystalloids intraoperatively is probably worthwhile. For patients, these findings suggest that being treated with bleomycin is not a contraindication to procedure. However, those patients may be at slightly higher risk for postoperative ARDS, but the risk is probably not as high as we have historically thought. If you compare our incidence of postoperative ARDS to the overall incidence of postoperative ARDS at the Mayo Clinic, you'll find that our incidence in bleomycin-treated patients is quite low. In fact, high-risk vascular, high-risk cardiac, and high-risk thoracic procedures have an incidence almost 2 to 3 times that of patients treated with bleomycin. Of note, of our 7 patients with postoperative ARDS, 2 of them had intra-abdominal sepsis, 2 of them were high-risk vascular procedures, and 1 had a cardiac arrest in the post-anesthesia care unit. This suggests that of our 7 patients, many of them were at high risk for postoperative ARDS, irrespective of their bleomycin use. The main take-home message from our study suggests that the true incidence of postoperative ARDS in bleomycin-treated patients is less than expected. It does not support the notion that restricting FiO2 in bleomycin-treated patients improves outcomes. However, it does not suggest that intraoperative FiO2 can be given indiscriminately. Our results also support the notion that limiting colloid and crystalloid administration is probably warranted. Further directions within this area of research would probably require a multi-center study to identify more patients with postoperative ARDS, which would allow for true identification of modifiable risk factors. This research was supported by the Foundation for Anesthesia Education and Research, as well as the National Institute of Health. I would like to thank Stephanie Newman, Rebecca Johnson, Arun Subramanian, and Gerald Schroeder for their work on this project.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.